the topic?
The topic. So I didn't get any information about the speaker. I didn't get the CV.
So, okay, so then
Will be
I'll introduce the
Yes.
speaker and you can
The
introduce the
CV will be
topic.
displayed and both of you can come and give your remarks on the topic also. So, Shashi Madam, you will be introducing the speaker.
Yes, sir. Yes, sir.
It will be displayed.
Okay, sir. And I've got it also. The CV Dr. Alim had said. So, I think.
Do you have the intro slides ready now?
Yes, sir. Yes, sir.
सर आपको बहुत दिनों के बाद आप डॉक्टर तूफानपति सर देख रहे हैं, आप ठीक है? तबीयत में ठीक है?
तबीयत तो ठीक है, लेकिन मीटिंग में हम तो आते हैं, एक ही मीटिंग मिस किया।
अच्छा, नहीं इस मीटिंग में नहीं, अदरवाइज जैसे कि
हाँ, मैं तो थोड़ा तबीयत ठीक नहीं था।
हाँ, मैंने कुछ दिन पहले कॉल भी किया था आपको।
हाँ, तबीयत इसमें ठीक नहीं था
अभी
थोड़ा।
ठीक है सर?
अभी ठीक है। जैसे होते हैं इसको तो ठीक समझना चाहिए ना।
ठीक ही रहेंगे सर, बढ़िया। डॉक्टर अलीम, इतने सारे एपिसोड के साथ गिनीज वर्ल्ड बुक रिकॉर्ड इसने ब्रेक कर दिया। This is
International Book of Records we have, world record. For International Book of Records, we have the record. So officially we have the record. Not from Guinness, but from International Book of Records.
And ma'am, we have just submitted the letter for the achievement to ma'am World Medical Association, ma'am. To
it's a
publish.
great achievement. 286 episodes चले जा रहे, चले, and all are very well attended. That is the
Alim
best.
sir, Amrit sir, ma'am, they are endless.
अमृतसर ज्यादा नहीं किया है। नमस्ते मैडम।
नमस्कार डॉक्टर साहब, कैसे हैं आप?
ये तो अंधेरे में दिख रहे हैं।
ट्रैवल कर रहे हो?
अमृत, एक काम करना, हेडलाइट के सामने आ जाओ, उधर लाइट ज्यादा दिखेगी।
बढ़िया।
कार के अंदर लाइट नहीं तो हेडलाइट जला ले।
अंधेरे में दिख रहे हैं, लेकिन तुम लाइट भी नहीं
आपकी डॉक्टर साहब आवाज कट कट के आ रही है।
मैडम।
बोल तुम रहे हो, नेट तुम्हारा गड़बड़।
उससे रैंक मेरे मैडम आधा मार्क एक्स्ट्रा पाया था एंट्रेंस में, उसका गुस्सा अभी
I think today's topic will be very interesting because the sort of approach that sir is taking, it is highly clinically useful.
Yes, sir.
and absolutely different.
During those days, my friends used to say the diagnosis begins when the patient enters the room.
That's true.
Yeah.
I think that is what he is going to demonstrate now.
Yes, sir.
And the process of diagnosis begins when the patient is walking in. Maybe he is here to demonstrate that.
Yes, we are thankful to him very much.
Very correct, sir. I'm showing in my slides, sir, that I had a teacher, KK Sinha in Ranchi, and he was a very well-known neurologist. his room was long, and he used to sit towards the road, towards the door, so that he could see the patient coming. And before patient used to sit, he started to write prescription. So gait is very important.
KK Sinha was the top neurologist in Eastern India, sir.
Yes, sir. He was an institution in himself.
Yeah, KK Sinha
उनको
was.
जीएसटी चाहिए तो डीएल जीएसटी सर दोनों रहेगा तभी तो जीएसटी वरना सर अगर आपकी बिलिंग होगी तो आप ही का लॉस होगा सर जीएसटी बिल कटेगी सर और आप जीएसटी बस ले नहीं पाएंगे सर एक बार ये चीजें ना एक बार अंकल जी से समझ लेना
अलीम किसका जीएसटी कटवा रहा है तुम यार?
जीएसटी कट गया आशीष जी का आशीष जीएसटी कट
अरे
गया
इंटरेस्टिंग टॉक सर गेट एंड जीएसटी सर
जीएसटी ऑन गेट.
आशीष भाई जीएसटी गया चलो आई थिंक वी कैन स्टार्ट नाउ 8 o'clock. Tufan sir?
Yeah, let's start.
Yes, so Shobit, you have to share the slides. So the
Yes,
host is muting everyone now. Only the panelists can unmute themselves. I think panel is made. Yes, I think we are all set now. Recording is on, na Shobit? Yes. Thank you. Thank you. Welcome all of you to this 286th edition of Thursday Musings. A very, very basic topic, very clinical topic, very clinically useful topic today. We'll be talking about the gait, how to use it to diagnose. We have a expert on the subject. We welcome you, sir, by heart. So the session is being recorded. This will be available on YouTube for later viewing. Then the questions are invited in the chat box. So you have to type the questions, put in the chat box. They will be taken up to the speaker. Next slide, please. So the chairman of this program is Professor Dr. Tufan Pati, sir. Sir is from Cuttack. So, sir, I'm handing over the session to you. Please take over and mute.
Hello, good evening. I was muted. Thank you, Dr. Alim. And I also welcome all our moderators, Dr. Amrit Patajoshi, Dr. Alim Siddiqui, and Vishal Gar for their vibrant moderation. Dr. Shobit Gar, excuse me. And for this vibrant moderation, I have the pleasure to introduce Dr. Shashi Rai. She is a consultant psychiatrist, MD 1989 from LHMC New Delhi, senior resident LHMC New Delhi, Pole Officer KGM in Lucknow, currently holding following positions: Director Sambal Drug De-Addiction and Psychiatric Hospital, Indira Nagar, Lucknow, Secretary Richmond Fellowship Society, Lucknow Branch, Member State Mental Health Authority Committee, Member District Mental Health Review Board, Advisor Leadership Development Task Force IPS, Secretary for Education and WDP India Chapter, Member Ethics and Law Committee WPA. Received BB City Oration Award for Central Zone, IPS UP State Branch Oration Award in 23. Received PKC Oration Award in Annual Conference of IAPP UP UK, and felicitated on Doctor's Day on 1st July. By Dr. Neeraj Bora, MLA Lucknow, received recognition on Doctor's Day celebration in IME 2019. Nominated for Women of Substance Award by Hindustan Times for the year 2018. Welcome, Dr. Rai. Next slide, please. Dr. S.P. Murugapan is the other chairperson in this meeting. He is MD DPM from Institute of Mental Health, consultant psychiatrist Ultimate Brain Clinic, Chennai, selected for Marfate Award presentation in ANSIF, Visakhapatnam 2022. Selected for Marfate Award presentation in ANSIF, New Delhi 2026. Conducted symposia and workshops in various ANSIFs, IPSCon and SHAP WPA conferences. QWG brain mapping with focus and theta gamma coupling, rich cloud networks, neuropsychiatry, RTMS and photoneuromodulation, QEEG trainer, areas of interest, conditions with neurophysiological basis, autism, ADHD, MCI, and dementia, HRV, RSA, autonomic dysfunction, neurofeedback, special focus to develop QWZ into personalized precision psychiatry, research tie-ups, Balaji Medical College, Chennai, and JSS Medical College, University of Mysore. There is a profound diverse area of interest of Dr. Murugappan. Welcome, sir. With this, I hand over the meeting to Dr. Murugappan and Dr. Sasirai. Kindly take over. Dr. Sasirai will be introducing the speaker, which is displayed, and both of you can give comments on the topic. Please take over.
Good evening, everyone. It's a privilege to be chairing a session in the Thursday Musings, one of the longest going on webinars, and I thank Dr. Tufanpati sir, Dr. Alim, Dr. Amrit Joshi, and Dr. Shobit Garg for having given me this opportunity. The topic today is use of Gait to diagnose, and the presenter for the topic is Dr. Rishikesh Kumar, who is MD, DPM, postdoctoral fellow in movement disorder. He's the Vice Chairman, Head of Neurology, Director, Research and Program Director of Movement Disorder, Institute of Neurosciences, Calcutta. He's got the Distinct Physicians Award, Government of West Bengal, Member, MDS Executive Committee, Chair-elect and Education Committee, International Movement Disorders, Professor of Practice in Newcastle University and Calcutta University, Fellow, Founding Member and former Secretary, Movement Disorders. He's got more than 200 articles to his credit, and research areas of interest are Parkinson's disease, inflammation, and neurodegeneration. It's a very important topic, gait disorder, as we were just discussing informally, that as soon as a person enters, one can think of what problem he has seeing his gait. So I'll hand over the topic to I'll request Dr. Murugappan to say a few words, and then we can all hear Dr. Rishikesh.
Sir, please unmute. Murugappan sir, please unmute.
No, the host has to unmute. We are not able to do it on our end.
They can now. Everyone is
Now,
supposed.
now I'm okay. Okay now. Thank you. Thank you for the opportunity. It is a very great occasion to say come across such a great learner and practitioner, and we are going to learn so many new things. And earlier he was telling about the gait. The diagnosis begins when the patient is entering the room, and he is going to demonstrate with his a lot of experience, and we can start practicing the same techniques whatever he is going to advise us. Yeah, I welcome Dr. Rishikesh Kumar.
Thank you, sir. All right, so thank you, sir. Thank you, everybody. And you have set up the stage very well. That gait is very important. And I would say that for last 2 weeks, I know better than everybody else because I had an ankle fracture and I'm cast right now. So now you can imagine that how gait is important. I'm walking on this wheelchair, you can say. So now I can imagine that gait is so important. We'll plan our discussion in various strata. One is knowing about why gait is important, but also focus on evolution of gait. And then approach to gait disorders as you asked that we should know clinical about the gait. We'll show a couple of cases and we'll show some relationship between developmental disease and neurodegeneration. So why gait is important? I can tell you the perfect jugaad for clinical neurology or for clinical psychiatry or anything clinical. You can imagine a OPD so crowded, how you can see the patients and how you can diagnose and write medication. So we have to have some jugaad in India. And in that case, gait is perfect jugaad. Once the patient comes to your room, you know that patient is shuffling. He is slow, one side more than the other side. That means Parkinson's disease. If the patient is spastic on both sides, that means patient we have to look for pyramidal tract. If the patient is ataxic, that means you have to look for cerebellum. So just after seeing in 5 seconds time, you know that which direction we have to go, and you can save a lot of time in that. I talked about KK Sinha. He was very senior. He did not teach me, but I saw his OPD, his clinic. His clinic was long one, where he used to sit towards the door, where patients, when they used to walk, he knew that what he is dealing with. And that was proper clinical neurology. Unfortunately, nowadays, what we see in corporate hospital, there's a like a prison cell, small room, shuru hote khatm ho jata, pata nahi chalta ki what is the gait. So it's very important to know about the gait. Now I will discuss a little bit of evolution before going into clinics. What made us stand on 2 feet? Think of normal walking. everybody of us who is there and who is outside here, we are product of millions of years evolution. We should feel lucky that it's not only us, it's millions of years behind us that has made what we are right now. In that case, gait and cognition are very important. Thinking of standing gait or bipedal gait is a gift of evolution, and it was very important. I'll see that why it's important. But at the same time, we evolved to walk on two at a lot of cost. Look at this horse, galloping horse. Can you gallop like this? No, because we are on two right now. We have to make balance. So we cannot gallop right now. This is a very old picture. And at that time, video was not there. So multiple still photograph was merged together. It was 1878. So gait, bipedal gait or standing gait, gait on two came with some cost. What cost? We lost speed. It added complexities. We became more vulnerable to spasticity, ataxia, and Parkinsonism. And you can see that even now, even athletes, when they have to run fast, they try to assume the horse or all four to start with before they go for the balance. Now, how we all evolved? How did evolution induct locomotion in the life? So earlier life, like salamander, lamprey, they were very millions of years back. They were there. They're still they are there. We can see when they or tadpole of the frog, when they move left to right like a sinusoidal fashion. So there was some generator of pattern in the spinal cord or in the brainstem was there that we call a central pattern generator that still can be seen in some sea lampreys. When you have the spinal injury, they walk left to right in a sinusoidal pattern, and so that was CPG. And I can tell you that CPG is still there in our brainstem and spinal cord, and that's why we have this bipedal gait. So this CPG is, where is the CPG? It's the upper spinal cord or lower brainstem, and that causes us to automatically walk to and fro. The right leg goes in the front and left stays behind, something like that. That has been further shown by Harrington cat, where patient cat was decerebrate, and they could see that despite being decerebrate, the cat could walk properly. And in a child, suppose you have 1 month child or 2 month child, when you keep like this, you can see that they walk this like a spinal gait as cat was walking, Harrington cat was walking. So CPG is still there, and which becomes overshadowed in due course of time as we evolve more, as we grow older. So basic CPG, that means pattern generator, is still there, which is being overrun by brainstem, then cortex and subcortical area. Another thing that is quite intriguing, that in some animals, when you see as soon as they're born, they try to stand up and walk. And that way, that again was the cost of evolution. In humans, you will see that she's my daughter, and at the age of 5 years, still she wanted to walk. When I was running, say, 5K, she was on my shoulder all the time. And why this happened, that in human being, it takes about 1 year time to stand up and walk, while in animals, it is quite earlier. And no clear answer to this is there, but they have shown that adult brain mass, lower the brain mass, earlier the chance of walking. More you are in the womb, earlier the chance of walking. And that way, human being, they are in disadvantage. Evolution also led to focus on pelvis, because pelvis flared up, pelvis in human walking. As we got up, as we had, so the child has to be in the womb, the pelvis flared up. And flared up pelvis is not physiological for walking or running on four. And at the same time, when we go back to some of the developmental disorders like Down syndrome, you can see that pelvis flaring becomes more prominent. Now coming to why did we made our hands free? Why we got up on two? Because as we evolved, we needed a child to be held, we needed food to be eaten, so our hands should be free. And you can see that as we evolved, the upright posture and gait, earlier there was a lot of water all over the places. To go through the water, we had to get up, we had our hands free, and that was one of the reasons, suggested reason that hands became free, upper hand became free, and we needed to walk on two. Another element is there that when we walked, I'm talking about millions of years back, when we walked in the water, when some object was there inside the water, when you look from the above, then a chance of having proper depth was there. But when you look from tangent, then you may not have proper depth, and that's why it's important to get up. And that's one reason by evolutionist biologists suggested to have walking too. Now, we talked about why it was important to walk on two. We talked about what we lost. When we started to walk on two, it was possibly 3 million years back. There was a skeleton found in Ethiopia in 1974 by some of the archaeologists. And what they found that one 1974, there was a female, which was 4 feet high, and bones were all over the places. And they combined that and they found a perfect skeleton. And that skeleton had all the character of upright walking. Now, one question to all the audience, name the syndrome. This is the case. This is the case where the all four walking is there and bipedal walking is lost. Name the syndrome, and we'll talk about that later. This was syndrome described in Turkey by one neurologist, and I'll talk about that later. All right. So we talked about why gait is important. We talked about evolution of gait. We talked that why we stood on two, and it was about 3 million years back. Now coming to clinical approach to gait and pattern of gait. We need whole neuraxis to walk. Think of spinal cord, think of peripheral nerve, think of brainstem. Everything is needed for walking, to start walking and for walking. So it's like a symphony orchestra. Any part of neuraxis, if it's abnormal, see cerebellum, you'll have particular problem in gait. If you have spinal cord problem, you have particular problem in the gait. Like in symphony orchestra, if some, say, violin player or viola player, he is not playing properly, the conductor will know that from that corner problem is happening, and that is the role of neurologists. That is the whole purpose of clinicians, to know that which part of neuraxis is affected when they see abnormal gait. All right, so I'll come to videos later. So patient's gait is trying to tell you a story, and we have to listen to or watch it carefully. Now, how to do that? So first we call as gait examination. We have to examine gait. And I can tell you in MD, MBBS, and even DM, we are taught motor system, we are taught reflexes, we are taught sensory system, but nobody is taught properly how to examine gait. And gait examination is nothing but seeing the person for a few seconds time, or maybe 2 minutes time. After seeing the gait, we see for the gait pattern, and then we decide that which part of neuraxis is involved, and then possible etiology. This is classical neurology. First examination, then you see the pattern, then you find that which part of brain or spinal cord is involved, and then what is the etiology. Most important of all the guide is stance base. When the person is walking or standing, what is the distance between the 2 feet? That is stance base. And stance base tells a lot of story. Look at the different stance base. This is a case of Parkinson's disease, where the stance base is narrow, and this is a case of PSP. Your stance base is wide. So just by seeing the stance base, we know that this is Parkinson's disease or Parkinson's plus syndrome. This is case of progressive supranuclear palsy, which is a bad disease which affects gait and balance quite early, and there's no treatment for that. And this is Parkinson's disease. The video is not playing, but it's a narrow base. So just by seeing the base, I can see that this looks like Parkinsonism, but this is PD and this is Parkinson's plus syndrome, like PSP. Coming to examination of gait, for residents at least or early career clinician, we should see that these are the points under which gait should be examined. And you can see that we start examining gait from seated position, how the patient is sitting. Is he tilting towards one side? Is he folding his head towards one side? How he stands from the seated position, how he is standing, how he started to walk and did walking, and how there was a turn and then some maneuvers. So let's see arising from chair. This gentleman had no proximal weakness, and despite that, he is not standing properly. He's trying to stand, but he's not able to stand properly. He's having to pull up. So this happens in Parkinson's or some Parkinsonism, that brain doesn't plan properly how to get up. For getting up, you need your leg to be aligned. You need your leg to slightly behind the knee, so that the center of gravity is on the same region. Now you can try one thing. You can put your both legs 6 inches front of a chair and try to get up. It's very difficult to get up. So brain has to plan how the body is aligned. Upper body is tilted a bit forward, leg is going a little backward, and that alignment we lose in Parkinson's disease or a condition known as higher level gait disorder. We also lose that in proximal muscle weakness, but not because of planning, because of weakness. In some cases of PSP, early PSP, they suddenly get up and they fall. They don't know that their balance is poor, they get up and they fall. This we see in PSP, what we call as rocket sign. So we saw arising from chair. And then we have to see how the patient is standing. Quiet standing, wide base stance is quite sensitive. A lot of problems have wide base stance, but narrow base stance is in Parkinson's disease. And in your chamber, your clinic, a lot of patient will come with PD, having psychosis or having anxiety or depression, spastic paraparesis, especially spinal cord disease or multiple sclerosis, or in some cases of HSP, hereditary spastic paraparesis. The stance will be narrow. We call it scissoring. progressive instability. They got up, and then the patient has, after say few seconds time, they start to fall. That is in functional also with psychogenic gait disorder, and in some cases orthostatic tremor. This is a condition where no tremor while lying down, but upon standing, the leg tremor starts. Excessive sway both sides, seen ataxia, dyskinesia in Parkinson's disease, and functional condition. Leaning sideways in case of skeletal problem and Pisa syndrome, truncal flexion, skeletal symptom, and camptocormia. Camptocormia is the word we use where the spine is flexed forward without skeletal problem, seen in Parkinson's disease. So we can see that when patient started to get up, we saw. When the patient standing, we saw, and we decided that which way the patient is going. Now we have to see that initiation of stepping, how you start stepping. While walking, what is the stance base, means distance between the 2 feet. Posture, stoop forward or going backward. Speed or cadence, associated trunk and arm movement, step length, and trajectory, shuffling or high steppage. I'll show some videos in that. So look at this patient. He's sitting properly. He tried to get up. He got up properly, and as soon as started to walk, he had start hesitation. Means he took few steps, say 5-6 steps to start walking properly. So this start hesitation, which again can be seen in some of Parkinsonism. So patient started to walk. While walking, we have to see that what is the posture. In this patient, you can see that right arm is not swinging. He's slightly stooped forward and on the side. So this classical Parkinson's disease. When the patient enters in a room like this, is classical Parkinson's disease, asymmetry, swing of arm, along with narrow base, stoop forward, and that's Parkinson's disease. Why seeing the patient walking and turning is important? Because it may look to you that patient is normal, but turning adds a lot of pressure on the brain. And you can see that while turning, patient has more problem. You can see that he's taking 3, 4, 5, 6, 7, 8, 9 steps to turn around. So it's not only walking, turning also we have to see, and that can reveal some underlying diagnosis. Some maneuvers we do: pull test, walking on tiptoe to see a weakness of gastrocnemius, walking on heel to see weakness of tibial centria, walking backward, some case of dystonia, they walk forward properly, forward with difficulty, but backward they walk normally. Tandem walk in cerebellar, Romberg sign in case of neuropathy or spinal cord disease, posterior spinal cord disease. Out of that, pull test is important for your clinic also, because balance we have to test in a lot of patients. For pull test, we stand behind the patient. We tell the patient that we are going to pull you with moderate pull, and you have to balance yourself using 2-3 backward steps. 1, 2, 3, 4, 5. So his pull test is not that bad. So that's pull test for you. Pull test is abnormal in a lot of conditions, including Parkinsonism, including cerebellum. And in case of functional disorder, pull test is generally not affected or affected in a different way. I'll show a video later on. So what we did till now, we have seen patient in different phases. We have seen when the patient was sitting, when patient was standing, when patient started to walk, turn around, then some maneuvers like pull test, Romberg's, tandem walking. So these are the tenets of examination. On the basis of these, we have to make pattern. And actually, neurology is pattern recognition in majority of cases. On the basis of seeing the gait, we fix some pattern, whether patient ataxic gait or bradykinetic gait or spastic gait, dystonic gait or higher level gait disorder. I'll talk about them one by one slowly. So in this case, you can see that the upper is normal gait. This is good footprint. If you have a big sheet of paper, if you ask the different patients to walk with, say, ink in the sole and walk like this, they walk like this. Normal is this. Spastic, narrow base, and you can see that crisscross, ataxic, wide-based, and irregular. Ataxic, the patient has wide-based, and individual step length will keep on changing. It's not regular. They will keep on changing. Parkinsonism, again, narrow base. And this frontal gait. Frontal gait happens when frontal lobe is involved. In case of NPH also, normal pressure hydrocephalus. In case of vascular Parkinsonism, so wide-based, but unlike cerebellar ataxia, you can see that is regular. Small steps, and later on the patient has festination, means shorter and shorter steps. In case of cerebellar ataxia, sometimes longer, sometimes shorter. There is no order at all. So this is very important imprint for various gaits. So what is this? This, you can see that wide-based. In the case of spinocerebellar ataxia type 3, wide-based, you can see that this was longer step, then again shorter step, longer step, shorter step. So it keeps on varying. And the patient is swinging on both sides. So this is classical ataxic gait. So once the patient enters to, and this cannot be Parkinson's disease. This cannot be PSP. This is classical ataxic gait. Bradycardic pattern I've shown you already. Narrow base is important. And because hear the sound, patient shuffling. He's not clearing the ground properly. And apart from that, you can see some other signs, like one side you can see rest tremor, again Parkinson's disease. So apart from gait, you can see some other signs, decreased arm swing, rest tremor, that again is Parkinson's disease. Sometimes you can hear the sound. You can hear the shuffling sound, again Parkinson's disease. So that was Parkinson's for you, the narrow base, short steps. You can hear the sound, shuffling, one side more than the other side, tilting towards one side, rest tremor may be visible. This spastic pattern. Spastic pattern, what happens, that looks like both, for the patient, looks like both legs are very rigid. And for you, it look like that both feet get stuck to the ground and patient is putting some effort to come out. You can say it looks like stuck to the ground and effort to come out. Apart from that, the angle of the knee is slightly bent in spasticity. In cerebral palsy, you will see similar gait. CP patients, you can see similar gait. If you see closely, the patient is not stooped forward. Patient is straight. This another case of spastic gait. Looks like whole leg. There's no movement in the leg. All the angles are preserved while walking. And the word we use in Parkinson's disease and in NPH also, in case of vascular Parkinson's also, is freezing of gait. What is freezing? Freezing has three components. When the patient start to walk, we call it start hesitation. That is freezing. When the patient turn around, we call it turn hesitation. That is also part of freezing. Or the patient can walk, but in the middle of that, suddenly he freezes. That's also freezing. Freezing generally happens anytime, but when the patient has to go through the narrow pathway or door, they have more freezing. You can see the patient is walking as he had to go on the gait mat, that's electronic mat. He cannot walk at all, and freezing happened. Right. Fascination is another word you will hear in the neurology. Fascination is the word where the patient walks, and at a particular point, it looks like he's running forward. His upper body goes forward, and lower leg doesn't follow that. So what lower leg does? Rapid small steps. A progressive increase in velocity and decrease in step length. That is fascination for you. So you can see that, you see it fascinated. He'll turn around, and again he fascinated. So this is not freezing. In freezing, patient stops. This is fascination. Then comes concept of higher level gait disorder. In say, what does it mean? Lower level gait disorder means peripheral neuropathy, where the patient's foot drop, or spinal cord, where the patient again has weakness. In case of middle level gait disorder, patient has Parkinsonism or spasticity. In higher level gait disorder, what happens? The upper means frontal cortex or subfrontal cortex means subcortical area. They are involved. In that case, patient has wide-based gait and sticks to the ground. This is Parkinson's disease, normal, and this is higher level gait disorder. Wide-based gait, sticking to the ground, and sometimes they fall on one side. So this term of HLGD or higher level gait disorder, it has reduced a lot of confusion, because earlier we used the word lower body Parkinsonism, arteriosclerotic Parkinsonism, gait apraxia, frontal ataxia, Mache petit pas, slipping clutch syndrome, magnetic gait. They all are encompassed into HLGD or higher level gait disorder. This is another case of higher level gait disorder. Wide based, you can say upper arms are moving, but legs wide based, short steps, and clearance is less. That's vascular Parkinson. That again one type of higher level gait disorder. So what it means that first of all we have to diagnose whether it's Parkinson's disease, means mid-level or higher level gait disorder. Once you think of higher level gait disorder, then it's not Parkinson's disease. It can be NPH, it can be vascular Parkinsonism, or frontal tumor, or any frontal involvement. So one question is asked all the time is for psychiatrists also, that in NPH patient can go to psychiatrist because of dementia and also because of some psychiatric illness, some psychiatric symptoms. How to diagnose that? In NPH, generally the gait is wide, as we all know. But at that age, because of vascular issues, a lot of patients have vascular Parkinsonism. In that case, also gait will be wide. But NPH is much more magnetic. In NPH patient, you'll see that both feet are glued to ground, as long as it can be. In some cases of NPH, the feet are everted, not front, it's everted a bit. And fascination, what we saw in that patient, that is less common in NPH and more common in vascular Parkinsonism. In this case of NPH, in this case, you can see wide-based. Each step is very, very difficult to get up. This from my fellowship days. And still he's clearing the ground. In some patient, it stuck to the ground. That's happening when he tries to turn around. But in this case, you can see no fascination. Freezing is also less. It's uniform throughout the walking. So that's NPH for you, unlike Parkinson's disease. So myoclonus is a word we use when there is jerky movement. So think of a jerky movement happening in the leg while walking, or a flurry of jerk happening in the leg while walking. It will suddenly stop the leg, and you will feel that patient is freezing, but actually it's myoclonus. This patient is a case of subacute sclerosing pancreatitis. He had some issues, but when it turns around, you'll see, yeah, you can see sudden we could prove electrophysiologically also. Sudden burst of myoclonus came and patient stopped. So myoclonus can also affect gait. Walking, sudden burst of myoclonus came and he stopped. So it's myoclonic gait in SSP. Dystonic pattern. So dystonia is the word we use when the muscles are there is excess contraction of muscle. The word we use co-contraction, leading to abnormal posture. So this case of young onset dystonia, genetic dystonia was TUB4 mutation, DYT4, but you can see that whole body is stiff, whole body is twisted, and he cannot walk properly. That is dystonic pattern. We are talking about pattern right now. All right, so we saw dystonic, we saw myoclonic pattern, we saw bradykinetic, we saw spastic pattern. In fact, in stroke, you can have a spastic on one side. Coming to coriform. This again is important for psychiatrists because some patients may go to the clinic with psychiatric symptoms, and due course of time, they develop chorea, means generalized movement, which is dancing type of movement, and chorea can affect gait, so coriform gait, and the case of HE, Huntington disease. So what's important here that while walking, there is unannounced movement of leg. Suddenly it goes up, suddenly it goes somewhere else. And unlike ataxia, it goes in, you can see the left leg. So left suddenly got up, that is coriform gait, and this is case of HD. Coriform gait can also be seen in the condition in your clinic again, in Niemann-Pick type C. These patients start with psychosis, young onset psychosis, and in many cases they are diagnosed as schizophrenia for 2-3 years, and then chorea develops, then walking difficulty develops. So he has white-based case, she has white-based case, some ataxia, some hand movement, you can see chorea. And when we have to diagnose this patient, you have to see eye movement. And again, eye movement is very important for all psychiatrists. If you have any psychiatric, say, gait disorder, look for eye movement. Again, I'll tell you one thing. In drug-induced Parkinsonism or drug-induced dyskinesia, everything can be involved, but eye generally is not involved, except in oculogyric crisis advanced case. So eye movement involvement is more of non-psychogenic, non-psychiatric. In this patient, there is vertical gaze palsy, which is seen in Niemann-Pick type C disease. I'm asking her to look up and down. She is not able to do that. And that's vertical gaze palsy in case of Niemann-Pick type C disease. All right, this patient, again, early onset psychosis at the age of about 12, 13 psychosis. And 2-3 years later, he started to have this gait difficulty. So you can see legs are stiff. So he has spasticity and wide-based falling, so ataxic. So this gait we call as ataxic spastic, and with onset of psychiatric illness. But in his case, when you see the ankle, there's a blobs of what we call as xanthoma, tendinous xanthoma. This is a case of cerebrotendinous xanthomatosis. So these 3 cases we discussed, Niemann-Pick type C, Huntington disease, and CTX, they all had psychiatric presentation, and later on they had gait problem, various gait problem. In case of HD chorea, Niemann-Pick type C, chorea and ataxia, and this case, spasticity and ataxia. This we already saw. We should not miss waddling gait. Waddling gait is can be neurological. I'm talking about movement disorder all the time, but in case of weakness of gluteus medius especially, waddling gait can be there, and this can be seen myopathy. Waddling is waddling both sides. Now, again, in your clinic, some young onset patient can come with depression, anxiety as a premotor symptom of early onset Parkinson's disease. And in the case of early onset Parkinson's disease, you can see that patient has become very, very stiff. Cannot get up or walk at all, very slow. When she was forced to get up, her walking was very slow. And she had some fascination. You can see that whole body is in a block. and she responded very well to levodopa, again proving that patient has young onset Parkinson disease. But this patient, after a few months of levodopa, developed bad dyskinesia, and that is feature of plateau J6, that's iron deposition disorder. So you can see bad dyskinesia. All right, so I'll come back to gait pattern. So this is very important. Spastic, narrow base, cerebral ataxic, wide base irregular, Parkinson, narrow base, and frontal, wide base, and short step, very short steps, which is seen in NPH. And on the basis of gait examination, we came to some gait patterns: bradykinetic, spastic, ataxic, coriform, myoclonic. And on the basis of that, we'll find neuraxis involved. Like ataxic, we know cerebellum. Coriform, basal ganglia. Parkinsonian, we know the substantia nigra and basal ganglia. In case of dystonic, we know basal ganglia. On the basis of that and age, we look for possible etiology depending upon the history and associated science. But there are some gait which defy any pattern. Let's look at this gait. It's quite historical, looks like crisscross. She turns around good. She suddenly falls. She goes sometime left, sometime right. But despite so much of posture, she didn't fall initially, and then she fell without injury. So this historical video, which is a case of functional gait, that was after time encephalitis. And when you see bizarre pattern, which is not fitting to anything, functional gait is one thing we should think of, especially when the patient has some bouncy character. Look at this patient walking, and suddenly she started to bounce at one place. This is generally unknown in organicity. Such bouncy character is generally seen in functional gait, functional disorder, especially when the onset is acute or subacute. So characteristic of functional disorder, it fluctuates with time. Sometimes she is good, sometimes she is not so good. Excessive slowness incompatible with neurological sign. Posture is uneconomic, wasting a lot of muscle energy, and walk on ice gait with small cautious steps and fixed ankle joints. I'll show one or two more videos to explain this. They have sudden buckling of knees, as you saw in that video. Suffering facial expression. There's no pain, but it looks like they are in lot of pain. They can have false positive pull test and false positive Romberg's test. This patient is a case of functional gait disorder. You can see that it varying. Sometimes left is stiff, sometimes right is stiff, and like to see his face. Somehow it's not. So he told that he has a lot of pain. So gait disorder with pain is highly unlikely, except in case of retinopathy. Such gait disorder in pain is less likely. They usually fall very safe. Look at the patient falling. So she had to fall, but things are not safe right now. So fall we cannot see. But when she turns around, you can see that she fell on me, right? So she was looking for something safe to fall upon, and that is usually seen in functional gait disorder, where injuries, I won't say unknown, but less common. By the way, this fall was not safe for me because she had vermilion and she fell on my white jacket, which is a cotton jacket, and I had to do a lot of explaining in the night time when I came home. Pull test we talked about. In pull test, what happens that when you pull test positive, you give pull, patient takes more than 3 steps, or they go back and fall. In this patient, what's happening? She's taking more than 3 steps, but you can see that she knew that nothing is there to hold her. At this point in time, she did not fall. So despite taking more than 3 steps, she did not fall. So this pull test again signifies most likely functional gait disorder. 2 terms I'll just mention here. Astasia abasia. Nowadays we use less. We put a block of functional gait disorder. Astasia means inability to stand. Abasia means inability to walk. Despite normal examination, everything is normal. That is astasia abasia. Patient appears to sway, swagger, or have near falls. When you see the first video, there's classical astasia abasia. When the patient, the historical video, in that case, astasia abasia is a phenomenon. It may be functional. It may be in some cases may be organic, but mostly functional. Then we use the word cautious gait, very adaptation to the perceived postural imbalance. Perceived, I'm talking about. They have wide base of support, reduced stride length, feet do not shuffle. Generally, in cautious gait, they are very slow. They'll walk slowly, but they raise the foot from the ground so that they don't shuffle, and so they don't trip. There's no reduction in feet to floor clearance. One group was functional gait disorder appeared after First World War, what we call as camptogormia or shell shock gait. So this was showed up after First World War. You can see that this looks like skeletal abnormality. Fall, again, did not injure himself. So this is very common at that time. Shell shock gait, and after some treatment, after some placebo treatment also, the patients, when they came from the front to the home, they improved in few days' time. They used to improve in few days' time, as you see in the later part of video. Yeah, so this patient again. So same patient after few weeks of coming from the front, and he was much better. So we talked about why gait is important. We talked evolution of gait, approach to gait and pattern of gait. I'll show a couple of cases, and we'll discuss about that. This patient came from my colleague Praveen Kumar, who's a psychiatrist. Patient was admitted acutely with acute gait disorder. What happened that he was watching TV in the night, and morning the TV was still on, and he was found to be very stiff, having this gait. You can see that very slow, almost like Parkinson gait. Truncal bradykinesia was there. His GTI was brisk. He could not speak at all, and he was a bit confused. So when you have acute gait disorder, you don't think of Parkinson's disease because that's slowly progressive. You think of something secondary. Brain was seen, MRI was normal. Then we thought it can be autoimmune, and lumbar puncture was done. It was normal. So no encephalitis, no vascular, no demyelination, and no autoimmune. And despite the patient acute onset gait, I'm showing this because this is a rare case, and we should keep in mind. Then we saw one more time, and penny dropped. You can see this patient again, and you can see a jaw movement. So this jaw movement is classically described in this slow myoclonus of SSP, subacute sclerosing panencephalitis. By the name, it should be SSP, but acute SSP is well reported. So rare case, and this was proven by EEG and lumbar puncture. Another case, she had depression, long-standing depression, and she presented with this ataxic gait. So 3-4 months of slowly progressive ataxic gait. You can see swing on both sides. And this patient in depression, what happens, he had this habit of taking something, I'll tell you later. MRI was not normal, so that ruled out functional gait. MRI showing hypointensity thalamus and basal ganglia. And she was taking this glue or sniffing, so tolling sniffing. So some patients who are anxious or who are depressed, they resort to some abnormal eating, abnormal pattern of eating, abnormal pattern of taking something, and she was glue sniffing ataxia, which was reported. I'll come back again. We talked about 2 cases, gait sense. So you examine gait, you see the gait pattern. I'll keep on repeating bradykinesia, spasticity, and other ataxic. You have neuraxis and possible etiology. So our last section is that examining relationship between developmental disorders and neurodegeneration. This is quite interesting again. It looks like that there's some link between neurodegeneration and developmental disease, and there's some proof for that. Think of Darwin and think of Mendel. Both were in same time in say 19th century, but they never met each other. Darwin talked about evolution, and Mendel talked about genetics. So if they sit together, they can think of that one tiny structure, which is the womb. It carries millions of years evolution. So this tiny structure genetics was field of Mendel, and evolution was field of Darwin. So both together we call it evo-devo concept, where each child or each kid in the womb, it carries millions of years of evolution, and that leads to the production of what we are right now. Autism, you see a lot of autism, and in some case of autism, when you see they walk toe, they have toe walking, and toe walking is much more common ASD or autism as compared to normal kids. And toe walking signifies that something is happening to them. It's like a spastic gait. It's like Parkinson gait. Something is happening in them, and some degeneration, some link between two are there, and that was proven that in case of autism ASD patients, when they follow for a long time, they have more common Parkinsonism. And that is started with toe walking, and that can lead to further, that can evolve into further problem in walking. In some developmental disorder, we see that feet design is different as compared to the normal people. Again, some problem in evolution has happened, and that led to persistence of evolutionary problem in the kids, and that led to developmental disorder. The risk of Parkinson autism spectrum disorder is well documented. In some case of ASD or autism, we have seen that there may be Trodat positive, which again is a feature of Parkinson's disease. In some cases of genetic Parkinson's disease, like PARK2, they are more common in autism spectrum disorder. MECP2 mutation, Rett syndrome, where Rett syndrome is seen, Parkinson's is more common. So I mean to say that Parkinson's disease we have seen in Alzheimer's dementia, they are more common in those people who have developmental disorder. Rett syndrome is a developmental disorder, but you can see rigidity, hypomimia, bradykinesia, and freezing are there. Some signs like applause and PSP and handling of Rett syndrome, it seems very similar clinically. In some papers, they have seen overlap between Alzheimer's and autism also. So this is the area which we have to work, which is the people are working, that developmental disorder may lead to, in due course of time, when age catches up, may lead to degeneration. So we talked about that. Now the last two slides, I asked that what is the name of the syndrome? This is Unertan syndrome. Unertan was a neurologist in Turkey, and he published this nice paper, which was very popular at that time. And he gave a concept that is reverse evolution of human, going from bipedality to quadrupedality. And he showed some pictures on that. Of course, there is lot of debate. Now we know that Unertan syndrome is not really reverse evolution; it's a genetic condition, and giving reverse evolution to human being is almost derogatory and scientifically irresponsible. So takeaways: evolution adds finesse and complexities, but makes us more vulnerable. Developmental disorders and degeneration often cross path, and Gait, which was the most important, Gait is most visible gift of evolution and most visible change when the disease strikes. For neurologists, for psychiatrists, for clinicians, seeing the Gait is very important. And the way we should see, first examine the Gait. It takes, say, hardly 30 seconds time. Then fix the pattern, which pattern the patient goes into, look for neuraxis, and look for etiology. Thank you very much.
Wonderful, sir. Thank you so much. Covering the whole spectrum of examination and history and everything. Very nice of you, sir.
Thank you, sir.
Thank you. Over to chairpersons for their opening remarks. Questions are invited in the chat box. So please type your questions, put in the chat box.
It was a very masterly presentation by Dr. Rishikesh. And one thing which I learned was, even when we see functional patients, we should not, just take it for granted that they are functional. We should see their gait and their eye movement, because as you showed in 2 or 3 slides, they had some problem or the other.
Yes, sir.
So, it was a great learning experience. So thank you for that. And over to the Dr. Murgappan, sir.
Thank you. Dr. Rishikesh, it was a wonderful session. It was enlightening. You have covered right from evolution of man from Gait to the Darwin and Mendel's. It was a wonderful session. It was a panorama of Gait. And we have learned something new which we never thought of, even that pull test in the functional gaits, as well as in ASD, gaits in ASD and the evolution. And it was eye-opening. And there is so much to learn, especially in, we never expected that there would be so many gaits in ASD or in any other conditions. The functional gaits, it was a wonderful revelation. And I have a doubt. See, I had a patient with cerebral palsy, about 24 years old girl, and with a normal intellectual, only with a mild motor disability. And she had a gait only on the right leg, right foot dragging, or maybe something like a certain, because I was not familiar with the gait now, as of now, and walking some kind of a circumduction gait, like, or just moving outward the foot. And that was the only physical deformity I noticed in the case of cerebral palsy. Can you say anything about that?
the cerebral palsy, they present with spastic gait. And so this circumduction is part spastic gait. In your case, unusual thing was that it was unilateral, because generally cerebral palsy is global hypoperfusion and or global hypoxia that can lead to bilateral gait. In your case, it's unilateral, which is uncommon but not unknown in cerebral palsy. What we say that both sides of brain, suppose they don't get oxygen, they have hypoxia and they can cause bilateral gait. But brain as a design, both sides are not made similar. So one side may have less threshold to hypoxia as compared to other side. And a lot of diseases, I would say hyperglycemia, we have chorea. That happens in one side only. Because brain as a design, one has less threshold of this damage. So in that child, it's possible that one side had less threshold and it got damaged, other side could not get damaged. And that's why this circumduction gait. So this was spastic gait. Circumduction is the word when you use that. It is most likely spastic gait. So patient has either asymmetrical spasticity or unilateral spasticity. In that case, baclofen or small amount of Botox in the adductor muscle, because circumduction is there, that generally helps.
Session is open for discussion. Any questions from the audience, viewers?
Yes, sir, if you allow. Sir, regarding the evolutionary thing, I was listening to a book and very interesting points that you shared, that because of this bipedal gait, the humanity has to bear the burden of cesarean section, because the pelvis has shaped and now the baby is not passing out. So the cesarean section is a side effect of humans walking bipedal. Would you agree with that?
Yeah, I agree with sir. We call it cost. We have to give some cost of getting up. Using the hand was very important. I'm eating through the hand. I'm taking my child in my lap when I have to cross the water. I've talked about millions of people back with the hand. So because of that, we lost a lot of things, including this cost of bipedalism. I agree.
Yeah, and another thing that was mentioned in the book was the human babies that are born, they are so helpless.
Yeah.
This is because the head size has to be small to pass through the small pelvis that has to be due to the bipedal gait. So the human babies are very helpless till around because the brain size is growing. If the full brain is grown, the birth cannot take place.
Yeah.
I think that is very interesting point that you pointed out.
It's very interesting. Two things are there, sir. One, we need bigger head to think, to have cognition. At the same time, we have narrower space to come out, right? So we have to come out early as compared to so growth keeps on happening after that also. And that means you are helpless when you come out. In case of horse, you saw that he came out and he started to walk.
So because of that, the gait is a complex thing, and because of that, Dr. Rishikesh is able to teach us the slight variation. So there is slight variation in something, it is presenting there.
Yeah.
So, sir, thank you so much. I think it was a bit fast for me because many things went by. Sir, you were telling that the brain frontal lobe is having those sort of. Can you just revise this slowly for our benefit?
So what happens? That's very important. The word is higher level gait disorder.
Yeah.
So high level gait disorder is a disorder where we use multiple names like Mache Petipa or lower body Parkinsonism. So in that case, what happens that frontal lobe is supposed, say subcortical area is supposed to give signal how to walk, signal to the legs, especially just in front of the frontal horn. So that plans for your legs. So when that is involved, your planning is not great. The word we use is apraxia, means everything is there. You can move your legs. You can. There's no weakness. The planning is not great. In that case, when you get up, you try to prevent fall. So your legs are wide based, because wide based means more balance. And then when you walk, the stride length is small, so that center of gravity remains close, so you don't fall. So wide base, small stride length, uppers, because arms is not involved, arm swing is preserved. So when you see this gait, we call as higher level gait disorder or frontal gait disorder, and these are seen in NPH or vascular Parkinson or frontal tumor. So there's a particular gait where wide base, short stride length, and preserved arm swing. That is frontal gait for you.
Okay, Shobit.
Sir, for the benefit of postgraduates who are there in the audience, so for examination purpose, what should be the exact say instructions to conduct the gait examination? So in terms of the length, the patient should walk, the turning, and how much the exposure should be there, sir, in terms of disrobing, sir.
Yeah. So good thing is that gait examination is less touch and more seeing the patient. In seeing the patient, at least arms should be uncovered. So the arm means your chest can be covered, but arm should be uncovered. Your leg should be covered till mid-thigh, but not below that. Knee should never be covered. You ask the patient to sit down calmly. Just see the patient sitting where the patient is tilting forward or sideward or backward. Then ask the patient to get up from the chair, preferably without pushing the arm of the chair, and then start walking. As soon as you get up, don't stop. Get up and start walking. 10 meter going and then coming back and sitting. So this is in this segment, you can see a lot of things: how they get up, how they stand, how they walk, whether they start hesitation or turn hesitation, and how they sit down. So 10 meters is one thing. Apart from that, we have to do some maneuver also. In that case, you have to touch the patient. That is 3-4 maneuvers are very important. Tandem walk is very important. Tandem walk, 10 steps. And out of 10 steps, we say that up to 1 to 2 is permissible. More than 2 means 3 or more is abnormal tandem walk. So tandem walk is very important. Tandem walk means cerebellar disorder or Parkinson's plus also they can have tandem walk. After that, this pull test is important. And then you can add walking backward. So these 3 are very important, and the list I've shown already.
Sir, interesting, very interesting. One thing which you shared was unannounced some movement in context of Korea, sir, in the gate.
Yeah.
Remember one of the patients I came across. Sir, sir, in continuity of the same, sir, just kindly, sir, explain to the audience regarding vascular Parkinson's and NPH, because we see, sir, a lot of patients with NPH, the magnetic gait, then how much, sir, they will stick to the ground. Sir, some clarity regarding that.
So first of all, Dr. Suvit, I'll tell you that no neurologist can be very confident that this is vascular or this NPH. There's some soft signs, but no can be, and that's why we do lumbar puncture to decide whether the patient is improving or not, right? We see radiology also. We know that radiology, but today I'll talk about clinical only. In case of vascular and NPH, both are affecting. Vascular Parkinson is the word we use. The subcortical area of the frontal lobe mainly that is involved. A lot of white matter stains are there. In NPH, what happens? That the frontal horn or this ventricle enlarges. So what they will do? They will do similar thing. The frontal subcortical area they will press NPH. In case of vascular, same area is involved. So there's a lot of similarity. But if you ask what are the dissimilarity, first of all, both will be wide base. In case of vascular Parkinsonism, there'll be less sticking to the ground. Means you can see that they can lift the leg up with each step. In vascular Parkinson, in NPH, right from the beginning, they are more sticking to the ground. We call it magnetic gait. That's more in NPH, number 1. Number 2, in case of NPH, they can stick to the ground, but they don't have fascination. Fascination is very important. In vascular Parkinson, fascination is quite common. What does fascination means? Means walking and suddenly rushing and falling forward. So that is more common in vascular Parkinsonism. We talked about white base. We talked about magnetic gait. We talked about fascination. Then in case of NPH, the feet, generally NPH is everted. Nobody knows the real reason for that, but everted feet means making more ground. So everted feet is more in favor of NPH, and straight feet is more in favor of vascular Parkinson. And then you see radiology, and we should go for this lumbar puncture.
Okay, sir. Okay, sir.
Okay, sir, and this, just to add it there, in CP, what are the gait and the lower limb dysfunction that we see?
CP is a condition which is a basket condition, which in which the patient has hypoxic damage or connectors or whatever happens, that leads to various parts of motor involvement. So when we see basket condition, anything can happen. The patient can have spasticity when pyramidal tract is involved. Patient can have ataxia. Patient can have dystonia. Patient can have chorea also. But out of that, spasticity is most common because the pyramidal cells are most vulnerable to hypoxia. So majority of patients of CP, they have this crisscross gait or circumduction on both sides. So that is CP. In case of CP, one can also have dystonic gait. Dystonic means curving of the leg, as you saw in one of the boy. In dystonic gait, what happens? Unlike CP, we call as all static disorder. Right from the beginning, they will have same. But dystonia is the only condition in CP which can appear later, means at the age of 7 years, 8 years, 10 years. So late appearance of dystonia doesn't rule out CP. So to answer your question, 2 patterns are common. One right from the beginning, spastic pattern, and later on the patient can have dystonic pattern.
Okay.
Thank you, sir.
Very interesting, sir, thing about camptocornea, sir. First, sir, actually explain the audience about camptocornea. So its presentation in dementia, sir, because we are seeing that. And sir, I read in one of the movement disorders group, there was a series on opioid disorders also. Patients who have chronic SMAG intake also presenting with camptocornea and its management also, sir. Please reflect some light on that.
Yeah. So camptocornea is the word we use, where there is a posturing of trunk Camptocomia is generally trunk and neck, right? Two words we should understand, we should know. One is Pisa syndrome, where trunk is tilted towards left or right. Camptocomia is forward flexion of whole body. It looks like kyphosis, right? Kyphosis or anteroflexion. So camptocomia is the word where the trunk is flexed forward with or without neck. So that's camptocomia. Then why kyphosis is not camptocomia? Another caveat is that without involvement of the skeleton. So in camptocomia, there is forward flexion of trunk or neck without involvement of skeleton. There's no fixed abnormalities. So camptocomia is reducible. If you ask, if you're confused that camptocomia or not, ask the patient to go to the wall and ask him to stand. You can see that he will become straight, right? So that's camptocomia for you. So camptocomia is in the absence of weakness, in the absence of skeletal problem, if the patient has this forward flexion, which is reducible, that is camptocomia for you. Camptocomia can be idiopathic, isolated also, but generally it affects, comes with Parkinson's disease or Parkinsonism. So what is the cause of camptocomia? One is Parkinson's disease itself, but some Parkinson's treatment also, like dopamine agonists, pramipexole and ropinol, they can cause camptocomia or they can aggravate camptocomia. So if the patient of Parkinson's comes to me with camptocomia, first thing I do, I stop this agonist. You can continue levodopa, but stop this agonist, right? Apart from that, some medications can cause that. Medication can cause that, like you are well versed with drug-induced dystonia, drug-induced, say, or dyskinesia. Drugs generally affects face, but drugs can also affect neck. And when neck is affected, it's more of retro. Drugs can also affect the spine. Spine means spinal muscles. So spinal muscle dystonia can be because of drugs, and that can cause camptocomia, right? Spine or rectus muscle. So in case of spine, it can go like this. If rectus muscle, it will go like this. So drugs can cause rectus muscle. What is happening is mainly dystonia. So think of dystonia of rectus muscle, camptocomia, dystonia of erectile spine in the back, the retrocolis. So it can be drug-induced, it can be idiopathic, it can be Parkinson's related. Treatment, if you know the drug, fine. If you know dopamine agonist, fine. If you don't know, it's tough to treat, difficult to treat. In that case, we give amantadine sometimes works. Amantadine is, amantadine is used in ballast. Baclofen sometimes works, but rarely. One other way is to give Botox injection in the rectus muscle, because rectus muscle is supposed dystonic, pulling the front, so Botox muscle helps, and then DBS is there. And of course, physiotherapy, we say all the time.
Thank you, sir. And just to again bring back, you have already told this. What will be the definite red flags? What will the definite pathological signs that should raise our alarm? As a psychiatrist, we are seeing a patient. So what are the the red flags that we should definitely consult a neurologist now?
In case of gait disorder, right, sir?
In case of gait, yes, only in case.
So one thing, in case of non-psychiatric, means ordinary gait disorder, is generally consistent. When we see consistency, means whatever you have consistency, that means it's more likely organicity. Consistency means imbalance for a while and then improving. That's less likely organic. Exceptions, nothing is black and white totally. Exceptions are there, like episodic ataxia, PKD. They can be episodic, but generally. Second is while walking is difficult, but a lot of pain on the face, right? So that there's more of psychiatric and less of organicity. I would say tandem walk and pull test are very important. It is documented also in my practice also. Tandem walk, when you ask the patient to do tandem walk in case of psychogenic gait disorder, they can do tandem walk. You will see the patient is wobbling all over the places, but foot is landing at right place. So that's very important. In case of ataxia, foot won't land on the right place. You will see that patient is almost falling, and suddenly get a up. You see the foot. If foot falling in the right place, tandem walk, most likely this is psychogenic. But foot not falling right place, then you have to send to neurologist. Pull test is very important. In case of psychogenic, when you do pull test I showed you, pull test can be normal in psychogenic, or they can show a lot of, say, movement, but they won't fall. In case of fall, means 2-3 steps and falling back, it's most likely organic. So pull test, tandem walk, consistency, lack of pain, these are all favor towards sending to neurologist. And then associated sign, means you see rest tremor, you see, say, unilateral weakness. Also, that's why all psychiatrists should know a little bit of neurological examination.
Sure, sir. Thank you. Shobit.
Sir, a few interesting cases we have come across about knee buckling, sir.
Yeah.
And can you throw some light on that, sir? So before that, sir, you used PKD, sir,
Yes.
paroxysmal kinesogenic dyskinesia. for the benefit of also audience, can you just explain that, sir? And then the question.
So this is a condition, this is channelopathy, as a genetic condition, usually affects young people, say 10 to 30s of age, where the paroxysm means episodes of dyskinesia. Means suddenly you will find for few seconds only, and they keep on moving like this, or their legs get stuck. So that paroxysmal dyskinesia is channelopathy. Now, this can be of two types. One is kinesiogenic, which is much more common, and second, non-kinesiogenic. So PKD is the word we use when you are standing in the line, those patients, and suddenly they have to walk. So sudden movement, start of movement, that brings out these movement, this abnormal dyskinesia, we call as PKD. Sitting, suddenly they thought I should go and put off the light. When they go up, they suddenly become dyskinetic. Dyskinetic means whole body started to move or legs started to stick. So that is PKD for you. Channelopathy, treatable, carbamazepine helps. So that's PKD for you. PNKD is less common, and PNKD same happens in episodes, but without movement. So PKD or PNKD can be easily be confused by psychiatric disorder and by epilepsy also. So seizure, if the patient has retained consciousness, less likely seizure. But in those cases, we have to do EEG also.
Okay,
Sir, we have seen in certain videos that they attach certain sensors to the to your limbs, and then they record the gait. So any comments on this? What is this machine thing that they're doing?
Sir, I have a Gait lab, and I have that what we're talking about. So Gait lab, but I showed one or two videos of walking on a mat. Mat was an electronic mat where the patient was walking, and as soon as they put in the foot, everything we get all the information. What is the force, what is the stride length, what is the width, and everything. But it's not giving information of upper body. That's only 2D. So for that, we put small, say, banded-like thing on multiple places, and there's a camera all over the places in the room that senses those banded, those sensors, and that creates a picture of the patient walking like a booth, like a ghost, means only lines. So sensors are nothing but seeing movement of not only soul, whole body part. So that is sensor, and that's generally camera based.
So neurologists usually keep it, or you're
This is very in India. We have 2 or 3, 4 labs only. This is a research tool. This is not going to help in clinics. We should not think about that. In fact, I would say that despite having lab, a good clinician's eyes are better than these labs at this point in time, because in some case I know that this is ataxic gait, but the sensor is not showing classical ataxia because it has different paradigm. So our eyes are still better at this point in time. Who knows that 10 years what will happen, but still better.
So clinical eye is the gold standard, sir.
No doubt, sir.
Sir, knee buckling, sir. Sir, can you just throw some light on that, sir?
So knee buckling, that means knee buckling is a phenomenon that can happen because of multiple reasons. One, I'll start one by one. I'll start quadriceps weakness. Any case of quadriceps weakness can lead to knee buckling. That can happen because of proximal myopathy. In child, they can have asymmetrical weakness of quadriceps that can lead to knee buckling. But more in our practice, we more see in Parkinson's disease, in case of sometime aesthesia abesia also. So what happens that when you walk, in case of Parkinson's disease, in case of spasticity also, you don't walk on straight, you walk slightly bent. So this leads to sudden fatigue and give way. So any patient, if we also try to walk with slight flexion of the knee, after some step we give way. So this can be, knee buckling is a phenomenon, can be because of focal weakness of quadriceps, or can be because of Parkinson's disease or any condition where this flexion of knee and you try to walk on that. And then when you talk about PKD can have episodes of knee buckling. Now I'll add a new, say, rare disease, glutamate deficiency syndrome, glucose transporter 1 deficiency syndrome. That also has episodes of this knee buckling, episodes of dyskinesia.
Okay, sir.
And
I'll share one patient because this is important for you all. A patient came to me. I was working in Canada with history of psychosis for a long time. Say 45 years old female, 8 years of psychosis, given a lot of antipsychotic, they developed abnormal movement, and we thought that drug-induced abnormal movement, right? But as the movement worsened, and then started to have ataxia. Ataxia is never seen in drug-induced movement. We went for a blood test and came out HD, Huntington disease. So HD can fool you. HD can present with psychiatric illness. You give antipsychotic, Movements will appear, chorea will appear. You feel that it's drug-induced chorea, but this is SD. So SD can fool you. And in that case, again, examination is important. If you see the impersistence, means ask the person to protrude the tongue out, and the patient is not able to keep for few seconds time. That is tongue impersistence. We call it jack-in-box tongue, or ataxia, or speech problem. Means when you think of any drug-induced Parkinsonism or drug-induced dystonia, they can have garbled speech, but not language problem. Language problem is unable to speak, some aphasia that goes in favor of HD. So HD is also important to consider.
Okay. Sir, it is said that longevity is dependent on having strong legs. So, would you agree on that? Your life is prolonged.
I have read about that. I would say I prefer to agree because generally I like to be very active, and I prefer to active when I see my patients also. Those Parkinsons who are sports person, like Chunni Goswami was a football player. He was my patient for a long time, and despite having Parkinson's for many years, and he lived till say 80 or 90. So strong legs means more physical activity, better cardiac health, less obesity. I can see from that angle, but yeah, I will agree for that. The reason I don't know. Simple reason can be you're more active.
Okay, sir. So you have said that basically for a psychiatrist who is sitting in the OPD, a 10-meter walk is okay for
10-meter
observing.
walk, you may not have space for 10-meter walk.
Yeah.
But, 10 meter is a, but at least say 8,
How
10
much?
steps walk, 10 steps, I would say 7, 8 steps, that's okay. Or if possible, if you have space and you suspicion, you can take the patient out and see walking 10
Okay.
meters.
And then you said tandem walk is very important and pull back is very important.
Yes, these three.
So these three things will help you screen out the gait thing.
Basic screening, right?
Okay. Okay, sir. I think we have covered all the questions. Shobit, we have asked all the questions that we got in our inbox.
Yes, sir. Yes, sir.
If you have to add one more thing in Gait, ask the patient to tap on the ground 10 times with the foot. In case of Parkinson's, the tapping will become slower and slower through both. So you can add this fourth thing for screening.
Okay.
So you tap with the front portion or the whole foot?
Oh, the best whole foot. Whole foot.
Whole foot. That kadam tal that is done in the.
Yes, something like that.
Standing or sitting, sir? Standing or sitting?
Sitting, sir. Standing, you may fall also. Sitting on the chair and doing this tap up and down 10 times, 10, 15 times. You'll find in Parkinson's, even you can hear that. First sound was good and then sound becomes less. In fact, what we see there, two things we see. We see that once you started to tap, earlier, the first few taps, ground clearance will be good, and gradually the clearance will be smaller. Or the velocity becomes slower and slower. That is in Parkinson's disease.
Sir, basic
Yes, sir.
more, sir. Sir, like a lot of patients, geriatric population comes to us. So how to differentiate whether they are having a slow gait because of pain versus neurological gait, sir?
Yeah, so two things I'll tell you that stance base is very important. In case of pain, generally base is not wide. One. Second, whatever even in pain, they can have this difficult walking. You can see that painful walking is there, but stance base as well as ground clearance. Ground clearance means shuffling or small foot and ground distance, more of this organic. And then you examine the patient, see circumtraction, you see bradykinesia, you see reflexes.
Okay. Okay.
So how to one question I have got.
Yes, sir.
So many patients, geriatric patients, come to us who are, having BPSD and also, Parkinsonism. How do you differentiate between drug-induced? If there is a comorbidity, Parkinsonism with EPS. How to do? There the treatment modality comes into place.
Yeah,
I think that's the commonest thing we face in our clinics.
So that's very good question, sir. Actually, you're talking about that idiopathic Parkinson's disease versus drug-induced Parkinson's disease. How to differentiate that? Because this is very common.
Yeah.
In that case, I'll repeat that again. That nothing is black and white, but few things. One is asymmetry. Parkinson's by rule is asymmetrical. In true Parkinson's disease, it never starts with both sides, right? It starts with one side first. It can become both sides, but one side first. When you see the patient, asymmetry, and even in advanced case of Parkinson's disease, asymmetry is preserved. First, it will be unilateral, then bilateral, but asymmetry is present. So one is asymmetry. Second, in case of BPSD, apart from BPSD, means Parkinsonism, let's find something hyperkinetic also. In case of true Parkinson disease, you will have bradykinesia, slowness, asymmetry, rest tremor, but not a dyskinesia. In case of drug-induced, some dyskinesia you'll find somewhere, lingual dyskinesia or payload dyskinesia. So that's one. True rest tremor, pill rolling tremor, is seen more in more Parkinson disease rather than BPSD. In BPSD, you find that they are slow, they are Parkinsonian, but true pill rolling rest tremor is more common in idiopathic Parkinson disease. And if you have, and then of course, the response to levodopa. It's a response to levodopa itself. Better response means idiopathic Parkinson disease. Apart from that, evolution. Generally, drug-induced Parkinson's to come to you with significant Parkinson's takes few months time. In true Parkinson disease, it takes 3-4 years time for significant symptoms. So slow progression, unilaterality, rest tremor, absence of peripheral movement, that all favors true Parkinson disease.
Many times the neurologists, what they do when I send somebody for a referral thinking that this is a idiopathic Parkinsonism, even though the patient is on antipsychotic, they just tell that it is because of antipsychotic, and then they don't even take 5 minutes to take a proper. This is a grudge I have got, sir. Many times we try to somebody is on antipsychotic and somebody also has Parkinsonism. That's where the problem comes. How to go about it?
I would say
Whether it is
I agree with you, sir. And in fact, there's a big chunk of patients who are really Parkinson disease, subclinical Parkinson disease. We give medication, Parkinson's comes out. That doesn't mean that it is mere drug induced. So it was Parkinson's there. It was waiting for something to bring it out. So this case is both drug induced as well as idiopathic Parkinson disease. So I would say in any doubt, I like to give levodopa because life quality is important. I like to give levodopa, syndopa, plus or whatever levodopa 2 or 3 times a day. And when you see the difference, you know it. One thing I'll tell everybody here that levodopa is a medication. Sometimes we are afraid of levodopa in case of using in psychiatric illness. In fact, levodopa is one of the safest medications. Dopamine agonists don't use, anticholinergics don't use, but levodopa can be tried for improvement in quality, and that helps in diagnosis also. But if you want real parameter, we go for DAT scan, true DAT scan. DAT scan is abnormal in Parkinson disease and normal in drug-induced Parkinson. But DAT scan is not available everywhere. It's very expensive, and I won't suggest as a routine. Means if somebody is rich and they want to go, they can go for that. Cheaper is giving levodopa and seeing the response.
But sir, then levodopa can always sometimes exacerbate the psychosis also.
Yeah, so any dopamine or dopamine agonist, as we discussed, that it can worsen psychosis, but when you see the figure of levodopa is minuscule as compared to any other dopamine agonist. So levodopa is still safe medication to give.
Thank you, sir. Thank you.
Thank you, sir. I think we have covered all the questions. So I think we can start winding up now. So final comments, any queries, comments from the chairpersons? Then we go to Tufan sir and then Amrit for the final thanks. Chairpersons, please.
So you are muted, sir.
So you're muted. It was an excellent presentation and there have been many takeaways.
Yeah,
And we've learned a lot from you.
Yeah, Murugappan sir.
Yeah, it was wonderful. Maybe we start applying it. And he has given you so many new ways to look at the patient. It was very nice.
Thank you, sir.
We thank Dr. Harish Kumar.
Thank you, sir. Thank you.
Thank you.
Tufan sir.
It was really wonderful, a condensed clinical teaching of say 3 to 4 months in neurology department. Condensed teaching. Thanks a lot to you. And what we definitely, personally, I would like to see this again through YouTube when it is uploaded. RLS, do you consider it a movement disorder?
Yeah, we try to bring into movement disorders because this response to dopamine agonist, and because it is associated with some other condition known as periodic limb movement of sleep. But RLS per se, it's not movement; it's a feeling, right? So in classical way, it should not be. But RLS patient we see, and it comes in movement disorders.
Well, thanks again.
Thank you.
And I hand over to Dr. Amrit Patajoshi for the vote of thanks. You are muted. Amrit, you are muted.
I think the way he took 3 or 4 parameters and explained everything, that was the best part. He did not give 10 points or 20 points. 3 or 4 tests, 2 or 3 things, how you examine. Based on those characters, those examinations explained. So thank you so much. It was really lovely hearing from you. Wonderful learning. I think after a long time, Alim has learned something out of this. Alim, thank you. Thank you to our chairpersons, Dr. Shashi
You
Madam,
tease each other, right?
Thank you.
You tease each other, right? Amrit and Ali.
Always.
Thank you and good night. I think we
Good night,
learned a
sir.
lot today, and you made a lot of things simple, sir. That's what is the hallmark of a great teacher, sir.
Thank you, sir. Thank you
Thank you
much.
and good night.
Thank you.
Thank
Thank
you.
you.
Meet you
Murugappa
again,
Thank
sir.
you
sir.
and good night to
Yes, sir.
everyone.
Thank you, Dr. Adi.
Thank you.
you.
Thank you,
Good
sir.
night,
Thank
everybody.
you. Thank you,
Thank
sir.
you.
Ending the
अब कुछ
meeting.
इनफॉर्मल टॉक हो सकती है क्या?